as you can see, as we said in the EPIDR studies, although most of them would like to fast, only 37% of the patients of type 2 were self-monitoring and 67% of type 1. Now, this is really not very good because we know of the side effects and we know of the complications of fasting during the Ramadan. Recently, the CREED study, which will be mentioned also by Dr. Mohammed in details, reported that 94.2% of type 2 diabetes patients would like to fast. Maybe he will tell us that not all of them fast the whole month, but still people like to fast. And we in our clinics are not there. We are there, of course, to tell them what are the complications of fasting. But if the patient says that he wants to fast and he presses on that, our job is to channel him safely during the fasting as much as possible. We are hoping to hear how best to channel our patients fasting during Ramadan, when to tell them they should not, when to tell them to break the fast. Are there guidelines for that? Because it's very difficult to deal with faith and with science at the same time, convincing our patients. And I will, before introducing Dr. Mohammed, I will recite one of the Quran verses. شهر رمضان الذي أنزل فيه القرآن هدى للناس وبينات من الهدى والفرقان فمن شهد منكم الشهر فليصمه ومن كان مريضا أو على سفر فعدة من أيام أخر يريد الله بكم اليسر ولا يريد بكم العسر. I will introduce Dr. Mohammed Jum'a, a senior endocrinology consultant, to tell us how we can share with the faith and the science to guide our patients into safe fasting. Dr. Mohammed is a senior endocrinology consultant. He is on the advisory board of many pharmaceutical companies. He has 10 or more papers that were recited in peer journals. He got his endocrinology Ph.D. and he had his MD and Masters of Internal Medicine. Without further delay, I would like to introduce Dr. Mohammed to tell us how best to tell our patients about Ramadan and fasting.
Okay. Thank you. This will stop other screen sharing. هل أعمل share screen؟
Yes, دكتور.
أعمل share screen هلا أنا؟
تفضل دكتور.
Share. Okay. First of all, I want to congratulate all attendees and the Islamic world. Also, I would like to thank Dar al-Dawa for sponsoring this scientific activity, and thank you, Dr. Taroub, for kind introduction. My talk will be about demographic studies regarding fasting in Ramadan in Islamic countries, risk of fasting in Ramadan, pre-Ramadan assessment for fast approval, who can fast in Ramadan, categories of risk according to IDF DAR guidelines, dose adjustment of medication during Ramadan, and also I will present 6 cases which cover all the aspects of diabetic patients we see in routine our practice in Ramadan. Every case I will discuss, and if there is any discussion or questions, please, at the end of the case, we can receive questions. Bismillah ar-Rahman ar-Rahim. This is one of the Quran I am holding in my clinic to show to the patient. يا أيها الذين آمنوا كتب عليكم الصيام كما كتب على الذين من قبلكم لعلكم تتقون. أياما معدودات، فمن كان منكم مريضا أو على سفر فعدة من أيام أخر، وعلى الذين يطيقونه فدية طعام مسكين، فمن تطوع خيرا فهو خير له، وأن تصوموا خير لكم إن كنتم تعلمون. شهر رمضان الذي ينزل فيه القرآن هدى للناس وبينات من الهدى والفرقان، فمن شهد منكم الشهر فليصم، ومن كان مريضا أو على سفر فعدة من أيام أخر، يريد الله بكم اليسر ولا يريد بكم العسر، ولتكملوا العدة ولتكبروا الله على ما هداكم ولعلكم تشكرون. Demographic studies nowadays, it is according to IDF 2019, there is now around 1.9 billion Muslim in the world, which making around 19% of the whole world population. And this figure is growing by approximately 3% per year. It is expected that within the next 2 years, the total number of Muslims in the world will be about 2.2 billion. According to the PDR study, which was conducted by Dr. Ibrahim Salti from American University of Beirut 20 years ago, this study covers around 12,000 patients from 13 Islamic countries. The study revealed that 43% of the patients with type 1 diabetes and around 80% of patients with type 2 diabetes, they do fast in Ramadan. This leads to estimate that worldwide more than 50 million people with diabetes fast during Ramadan. This was actually 20 years ago. Nowadays, according to IDF DAR guidelines 2016, there is more than 148 million Muslims with diabetes worldwide. And according to CREED study, 94% of those patients, they are trying to fast. 67% of them, they fasting every day. The average duration of fast, it was 27 days, and 32% of them, they are trying to fast, but not every day, but the total days of fasting, it is more than 15 days. According to the CREED study, nowadays, 125 million Muslims are trying to fast. Around 78 million Muslims are fasting every day for the whole month. And around 40 million diabetic Muslims, they are fasting not every day, but for a total of more than 15 days. Those figures applied only for type 2 diabetes. What is the risk of fasting in Ramadan? We have actually 4 major risk categories. The most important of them, hypoglycemia, then hyperglycemia, diabetic ketoacidosis, dehydration, and thrombosis. What about hypoglycemia? According to a PDR study, the risk of severe hypoglycemia, which needed hospitalization, was around 4.7-fold increase in patients with type 1 diabetes. And for type 2 diabetes, it was 7-fold increase in patients with type 2 diabetes. It is according to a PDR study 20 years ago. According to CREED study, which was conducted in 2010, and it is published in details in 2016 and 17, which covered around 3,000, it is less as a population. It is less than a PDR study. It is around 3,000 Muslims from 4 continents, Asia, Middle East, North Africa, Europe. Here, if you are concentrating on the Middle East, according to this study, the rate of hypoglycemia overall, it was 4.1% overall. But according to categories of risk, if we see here at the end, patients with very high risk, the incidence of hypoglycemia, it is 6.1%, which is even higher than the PDR study. if you remember in the PDR study, the risk in type 2 diabetes, it is from 0.4 to 3 events per 100 patients per month. It is the maximum 3% here. But in a CREED study, overall, in the overall, it was 4.1% from diabetic Muslim who fasting in Ramadan, they experience hypoglycemia. And in patients with high risk, it is about 6.1%. But if we look according to the CREED study, if we take into account patients who experienced hypoglycemia in the previous 3 months before Ramadan, the risk is much higher. Here in the Middle East, if you look, the risk of hypoglycemia, it is 20% in patients who experience any episode of hypoglycemia in the previous 3 months of Ramadan. But in North Africa, the risk is tremendous. It is around 42% risk of hypoglycemia. And in Europe also, and the total risk of hypoglycemia, it is around 35% in patients who experience any episode of hypoglycemia in the previous 3 months before Ramadan. Therefore, those patients who experienced hypoglycemia, we'll talk about it later, they are very high risk category and they must not fast at all. What about hyperglycemia? According to the PDR study, this study showed that the risk of hyperglycemia, which required hospitalization, it was 5-fold in type 2 diabetes, and this risk was 3-fold in patients with type 1 diabetes, whether with or without diabetic ketoacidosis. Diabetic ketoacidosis, it is common in type 1 diabetes. It is usually not common in type 2. In type 2 diabetes, they experience hyperosmolar state, hyperosmolar coma, not diabetic ketoacidosis. Usually, diabetic ketoacidosis, it present in patients who were poorly controlled before Ramadan, and they are trying to fast in Ramadan, particularly in patients who are reducing their insulin dosages to avoid hypoglycemia, which is a very common practice, unfortunately. What about dehydration and thrombosis, limitation of fluid intake, high sugar with polyuria, excessive perspiration in hot climate with humidity leads to dehydration. This could precipitate hypovolemia and orthostatic hypotension, and this could increase the incidence of syncope, falls, injuries, and bone fractures. Hypovolemia also increased blood viscosity, and there is increased risk of thrombosis and stroke in Ramadan. Pre-Ramadan assessment, we have actually 2 guidelines. This is the old guidelines, EDA 2010. And we have also IDF-DAR guidelines 2016, 2017. It is very important pre-Ramadan, this is the ideal that the patient must come 2 months or 1 month before Ramadan for to do blood sugar measurements, HbA1c, lipids, blood pressure, kidney function, and also to give him instruction regarding diet, regarding fluid intake, regarding exercise, regarding monitoring of glucose during Ramadan, and when to break the fast, and to adjust his medication. This is very important. This is the major issue of structure education pre-Ramadan. It is about nutrition, exercise, breaking the fast, and avoid fasting in sick days. And this is the change of medication according to ADA 2010. We will talk about in details later. This is the categories of risk, which is very important, which is introduced by IDF 2016. We have actually 3 categories: very high risk patient, high risk patient, and low to moderate risk patient. The Very high risk patient category, those with severe hypoglycemia within 3 months prior to Ramadan, which we talked about previously. Diabetic ketoacidosis within the past 3 months before Ramadan. Hyperosmolar coma 3 months before Ramadan. History of recurrent hypoglycemia. History of hypoglycemia unawareness. Poorly controlled type 1 diabetes. Acute illness. Pregnancy in pre-existing diabetes or gestational diabetes treated with insulin or sulfonylurea, chronic dialysis, or chronic kidney disease stage 4 and 5, advanced macrovascular complication, old age with ill health. All of those patients with those conditions, they must not fast. Here it is red line. The other category, it is high-risk patient, one or more of the following. Type 2 diabetes with sustained poor hypoglycemic control. Well-controlled type 1 diabetes, it is high-risk patient. Well-controlled type 2 diabetes on multiple insulin dosing or mixed insulin. Pregnant type 2 diabetes or gestational diabetes controlled by diet only or metformin, this is a high-risk patient. Chronic kidney disease stage 3, stable macrovascular complications. Patients with comorbid condition that present additional risk factors. People with diabetes performing intense physical labor. Treatment with drugs that may affect cognitive function. Usually depressed patients or patients, all elderly patients who are living alone and they're taking a lot of antidepressant or sedative. They are high-risk patients. But if you notice to the right here, if patient insists on fasting, then they should receive structural education, be followed by a qualified diabetes team, check their blood sugar, self-glucose home monitoring frequently, adjust medication dose per recommendation, be prepared to break the fast in case of hypo or hyperglycemia, be prepared to stop the fast at all in case of frequent hypo or hyperglycemia or worsening of other related medical conditions. This is very important. We must be, as a physician, very flexible, not to tell the patient only you must not fast and that's it. Sometimes the patients, due to religious, due to faith, they are insisting to fast despite all the risk the fast carry with it, but they insisted to fast. In such case, our role as a physicians to help the patient to minimize the risk and to whether the risk of hypoglycemia or hyperglycemia, to keep it as minimum as possible. The last category, it is low-risk patient or moderate risk patient, patients who are controlled on lifestyle modification or metformin, acarbose, TZDs, second-generation SU, incretin-based therapy, SGLT2 inhibitors, and basal insulin. Those patients can fast easily and safely, maybe sometimes with dose adjustment, particularly for sulfonylurea and basal insulin. We will talk about it later. This is the guidelines published in 2017. It is according to the IDF guidelines, which was published in 2016. This is the pre-Ramadan assessment, as we mentioned. Here, low-risk category allowed to fast, moderate or less low-risk patient. Frequency of self-glucose monitoring 1 to 2 times per day, it is enough. But here, the very high-risk and high-risk patients advised not to fast. If they insisted to fast, we must do some modification and they must receive very structured education before Ramadan. All patients, all categories, they should break the fast if blood sugar reach below 70 milligram deciliter, or if blood glucose above 300 milligram deciliter during the fast, or symptoms of hypoglycemia or acute illness occur. In one study, the importance of diabetic education before Ramadan, there is one study which is called READ study, demonstrated a significant decrease in the number of hypoglycemic events in a group of patients with type 2 diabetes that received diabetic education from 9 events pre-Ramadan to just 5 during Ramadan, compared with an increase from 9 events to 36 events in the control group that did not receive the education advice, which emphasize the importance of diabetic education before Ramadan. How much the high-risk category, they must do frequent glucose monitoring. According to these guidelines, they must do around 7 blood glucose monitoring, or they can use continuous glucose monitoring by new devices like Libre. But in the majority of patients, I instruct my patient to do blood glucose at 10 p.m. This is the most important, to examine whether there is hyperglycemia after iftar, and to do it around 12 midday and 6 p.m. to be sure whether there is no hypoglycemia and whether our medication and our regimen work well or not. Whatever the regimen you modify during Ramadan, you have to instruct your patient to do frequent glucose monitoring, as I mentioned, in the first few days of Ramadan, to adjust the regimen by telephone according to glycemic response. You cannot predict the response always. Despite your experience, despite what you expect, you cannot every day or always predict the response, whether it is adequate or not. This is therefore any strategy, any modification, it must be tested during the first few days of Ramadan by frequent glucose monitoring for those adjustments later on. Questions: what is the percentage of diabetic patients who attend the clinic before Ramadan for assessment? Unfortunately, in my experience, it is very low, maybe less than 2%. Despite we're doing a lot of lectures and the patients get more education and through the media and through the internet, but the majority of patients, they do fast or trying to fast on depending on their previous experience, not upon the recommendation of their doctors. In order to reduce the risk of hypoglycemia, large number of patients who fast, they reduce the dosages of their medications or eliminate some of them completely on the expense of high rate of hyperglycemia, which they tend to ignore or going unnoticed. Because the majority of patients, they do self-glucose monitoring only when they experience symptoms of hypoglycemia. They reported to me later that they did fast in Ramadan and everything was safe and okay. But if you check in the majority of patients, if you check HbA1c after Ramadan, you will notice that it will go up in the majority of patients after Ramadan in comparison with the previous level before Ramadan, which is unfortunate. What about those adjustment of medications during Ramadan? Metformin, usually there is no dose adjustment, remains unchanged. If the patient is taking 2 grams, he can take 1 gram at iftar and 1 gram at suhoor. If he's taking 1.5 grams, it is better to give 1 gram at iftar and half a gram at suhoor. Regarding acarbose, no dose modification at all. PZDs, no dose modification at all. It can be given with iftar or suhoor. Regarding short-acting insulin secretagogue like ribaglinide, usually I give it only on iftar, although here it is in the guidelines written that you can give it as suhoor and iftar. but it is risky to give it at suhoor. I noticed a lot of hypoglycemia if you give Novonorm ripaglunide at suhoor. I give a loading dose at iftar only. Regarding GLP agonist, there is no dose adjustment if the patient was already on GLP agonist before Ramadan. Of course, do not start GLP agonist on the start of Ramadan because you want to titrate the dosages gradually, and they could cause nausea and vomiting. And this dose titration, it took around 3 weeks minimum. DPP-4 inhibitor, they do not need any dose modification. You can give either once daily or you can give it on 2 doses at iftar as suhoor. Regarding SU, it is better not to or to avoid first generation sulfonylurea like glibenclamide because the risk of hypoglycemia is tremendous. It is better to use second generation sulfonylurea like gliclazide and glypiride. I favor gliclazide, which has a low rate of hypoglycemia in comparison with glypiride. Usually I give those only at iftar because those medication cover 24 hours. I do not give at suhoor. Regarding SGLT2 inhibitors, there is no dose adjustment. Those should be taken with iftar. Extra clear fluids should be ingested during non-fasting period. From iftar to suhoor, I instruct all patients to take a lot of fluids and should not be used in elderly patients with renal impairment, hypotensive individuals, or those taking diuretics. We will talk about DPP-4 inhibitor and SGLT2 inhibitor in more details. Regarding DPP-4 inhibitors, there is a lot of randomized clinical trials done with sitagliptin. This is one major clinical trial, and actually there is 4 clinical trials done with vildagliptin. Regarding sitagliptin, there is one large clinical trial comparing sitagliptin with SUs, and overall the risk of hypoglycemia was significantly lower in patients on this sitagliptin-based regimen compared with those continuing on SU treatment. And relative risk reduction, it was 50% around. But the risk of hypoglycemia between sitagliptin and gliclazide were equal. Regarding vildagliptin, we have 4 major clinical trials, some of them control trials, some of them observational trial. In the multi-center, multinational trial steadfast study, patients with type 2 diabetes were randomized to receive either vildagliptin or gliclazide during Ramadan. No significant difference in the reporting of any hypoglycemic event was observed between the 2 groups. However, the proportion of patients experiencing at least 1 confirmed hypoglycemic event during Ramadan was lower in vildagliptin compared with the gliclazide, 3% vs 7%, and it was highly significant. There is another number of observational studies that has examined the efficacy and safety of vildagliptin. We have a vector study. No self-reported hypoglycemic events were reported in the vildagliptin group compared with 35 events in 15 patients in the gliclazide group. In addition, the change in glycated hemoglobin, HbA1c, was lower with vildagliptin based regimen compared with gliclazide, and it was highly significant. It is in vector study. We have also VERDE study, which compared the incidence of hypoglycemic events during Ramadan in patients who are receiving vildagliptin or SU glenide medication, and found no significant difference in the number of patients experiencing at least 1 hypoglycemic event. However, the proportion of patients experiencing severe hypoglycemic event or unscheduled medical visit due to hypoglycemia were significantly lower in the vildagliptin group. In the Virtue study, which conducted in the Middle East and Asia, is the largest observational studies to date and enrolled more than 1,300 patients with type 2 diabetes. Significantly fewer patients treated with DPP-4 inhibitor vildagliptin experienced at least one hypoglycemic event during Ramadan compared with SU. Here with vildagliptin, it was the incidence of hypoglycemia 5.4% vs around 20% with SUs. And there was significantly a greater reduction in HbA1c and also greater reduction in body weight from baseline compared with those on SU. I mean, comparing vildagliptin with SU, there was significant reduction with vildagliptin arm in terms of reduction of body weight and HbA1c. All of these studies confirm that DPP-4 inhibitor, particularly sitagliptin and vildagliptin, they are very safe in Ramadan, and they are there is a low rate of hypoglycemia, and there is no dose adjustment. Those new medication like alogliptin, saxagliptin, and linagliptin, there is no randomized clinical trials done during Ramadan. What about sodium glucose cotransporter SGL2 inhibitor? There was a concern actually before, upon the introduction of this class, there was a concern that this class could cause dehydration, deterioration of kidney function, euglycemic diabetic ketoacidosis, and risk of falling down or fractures. But with the actually with the passage of time, there was conducted 3 major clinical trials done with dapagliflozin and 1 trial done with canagliflozin. And all these trials, this 1 trial with DAPA and another, this trial with DAPA, all of them, the conclusion was the same, that dapagliflozin was well tolerated in patients during fasting in Ramadan without an increased risk of dehydration or diabetic ketoacidosis or falling down or hypovolemia or deterioration of kidney function. This is another study done with canagliflozin. This is another study with dapagliflozin, and there is no risk of hypoglycemia and no dose adjustment. According to Canadian guidelines for diabetes, here there is a 3 statement. SGL2 inhibitor can be continued during Ramadan to maintain glycemic control and with low rate of hypoglycemia, evidence grade C, level 2 for canagliflozin and grade C, level 2 for dapagliflozin, grade D consensus for IMPA because no trial done with empagliflozin. Dose reduction or temporary hold for SGL2 inhibitors medication should be considered for people at high risk for volume depletion. Usually they are age above 75 years, eGFR below 60, and or on loop diuretics. This is a consensus grade D evidence. It is not based on randomized clinical trials. For people with clinical cardiovascular disease, SGL2 inhibitors should not be held during Ramadan due to their role in reducing major cardiovascular events and heart failure hospitalization. This is a grade D consensus. But again, these guidelines were done 2018 before the, as example, before the results released of the CLARE study and the CREDENCE study. I think those guidelines maybe will change regarding patients with chronic kidney disease. I think they can fast also Ramadan, particularly stage 1, stage 2, and stage 3A. Regarding type 1 diabetes, patient who must not fast at all, history of recurrent hypoglycemia, hypoglycemia unawareness, poor diabetes control, brittle diabetes, non-compliance with medical treatment, Patients who are unwilling or unable to monitor and manage their blood glucose levels. This is the insulin dose adjustment for type 1 diabetes, and it is applied also for type 2 diabetes. I only gave basal bolus regimen. I discontinue premixed insulin, whether it is a premixed insulin, old like Mixtard, or a newer generation of analog insulin like Novomix. I discontinue all of them because this class cannot control diabetes properly in the majority of cases, and you can experience hypo-hyper. But with basal bolus regimen, it is better regimen. Regarding the basal insulin, you have to reduce the total daily dose by 20%, and the dose of rapid-acting insulin must increase 30 to 50% at iftar, and must be decreased 30% at least on suhoor. And the patient must be instructed to do continuous glucose home monitoring by a new machine like Libre. Break the fast if any blood sugar reading drop below 70 mg/deciliter. In case of frequent hypoglycemia, hypoglycemic episode, despite insulin adjustment, I instruct the patient to not fast at all during the whole month of Ramadan. Nowadays, with the introduction of glucose pumps, particularly a closed loop system like Minimed's 670G hybrid glucose loop system, these pumps usually, they do have continuous glucose monitoring, and they send via Bluetooth the blood glucose level to the pump, and the pump infuses the proper amount of insulin. With those pumps, a very highly advanced pump, a lot of patients with type 1 diabetes, actually, they can fast in Ramadan, but those pumps are very expensive nowadays. When the cost will come down, I think it is good options in type 1 in diabetes. Till now, there is no large randomized trial done with those pumps in Ramadan, just case studies or few cases description successfully managed with Ramadan. Very interesting, those pumps can give you alarm if glucose going below 70, and they stop. They are very clever. They stop insulin infusion, and they also give you alarm if blood sugar, as example, above 150, and they increase insulin infusion automatically. Now we finished the theoretical part of our lecture. We will go for case presentation. If any questions before we go to case presentation, Dr. Taroub Khoury, please.
Yes.
Dr. Taroub?
Yes, Dr. Mohammed. Thank you very, very much for this really well-prepared, thorough review of how to deal with people with diabetes in Ramadan. I have till now 4 questions from the participants. One of them is saying, is the consumption of slow sugar after iftar, does it help to carry out the sport during the following day? I would like to say, you didn't mention about exercise in Ramadan and when is best to do it.
Yes.
And I'm not sure about the question is consumption of slow sugar will help the second day.
Regarding exercise in Ramadan, it is advised not to do vigorous exercise. It is very essential because vigorous exercise more than 30 minutes, it can precipitate hypoglycemia and more dehydration and the risk of hypoglycemia. Therefore, it is recommended to do exercise usually just like, as example, walking around less than 30 minutes. About ingestion, slow sugar after iftar to help them do exercise, I don't think it is a wise, good idea, because at the end of the day, everything we eat, it will be converted in our liver by gluconeogenesis. It will be converted to sugar in the majority of cases. I don't think it will help to do any exercise. I don't think it will rise blood sugar without any benefit regarding exercise.
There is another question. During Ramadan, if a person who does not have diabetes get hypoglycemia, what do you do?
During Ramadan, if a patient is not fasting, you mean?
No, he is not a diabetic person. He doesn't have diabetes, but he presents with hypoglycemia.
To my experience, hypoglycemia without diabetes, without ingestion any medication, it is very, very rare occasion. And in the majority of cases, it is a pseudo-hypoglycemia or relative hypoglycemia. It is usually we can observe in patients with insulin resistance. Usually it is after 3 hours or 2-3 hours after ingestion, a large meal, particularly very rich with carbohydrate or sugar. After 3 hours, there is a drop in blood sugar. Usually there is a steeping drop blood sugar, as example, from 150 to 70 or 80, and the patient, they experience symptoms of hypoglycemia, but it is not a true hypoglycemia, it is relative hypoglycemia. We must examine in such patients C-peptide and insulin and random blood sugar during hypoglycemic attack.
Thank you.
Of course, insulinoma, it is a possibility, but it is very, very rare case. Insulinoma, the prevalence of insulinoma, it is usually 1 case to 500,000 population. It is very, very rare cases in insulinoma. The majority of cases which we see, it is related to insulin resistance.
Thank you.
Of course, there is some cases in patients with as example, insulin deficiency or Addison disease. They are prone to risk of hypoglycemia, but usually the diagnosis is evident in patients with Addison disease or growth hormone deficiency after pituitary surgery. Another question?
Another question is very interesting about the level of creatinine, where you would tell your patient not to fast. Patient with diabetes.
Not the creatinine level, it is actually the GFR.
GFR, exactly.
According to the guidelines, patients with the stage 4 and 5, which is GFR below 30, they must not fast. They are very high risk patients. Patients with the stage 3, they are high risk patients. Stage 3, it is GFR between 30 and 45. They are high risk patients and should not fast. But nowadays, with the introduction of SGLT2 inhibitor, a lot of trials done in patients with, but not in Ramadan, of course, done with SGLT2 inhibitor in patients with the stage 3, and they show a benefit, particularly Credence trial. It is done in patients with eGFR above 30. And there was evidence that this class reduced cardiovascular events and this class preserved kidney function and reduced the need for dialysis, end-stage kidney disease, and need for transplantation and renal-related death. But I must stress again, those trials done not in Ramadan, and we cannot extrapolate this trial to Ramadan, of course, no randomized trial done in Ramadan with such, but I think we can say it is a consensus which could be changed in the upcoming years, that those patients with eGFR, particularly above 45, they can fast in Ramadan. With liberal fluid intake between iftar and suhoor.
Okay. Do you have a guideline through your experience that can be taken in our clinics? One of the questions.
The very comprehensive guidelines as IDF DAR study, which guidelines, which is 2016. It is around 150 pages. It is comprehensive guidelines, I think. You can also take Canadian guidelines. It is published 2 years ago. I found it very summarized, good, and very short. Maybe it is around 3 pages about fasting in Ramadan. And I think it is a good one also.
Can you help us the difference between glycoside or DPP4 in Ramadan? What do you advise them to use, glycoside or DPP4?
I advised inhibitor, the risk of hypoglycemia is almost negligible. Although the risk of diamicron glycoside, it is less than other sulfonylurea, but the risk is there. Therefore, if I prefer to use DPP4 inhibitor based regimen. I will show you in some cases in practice, we use 3 medications, we use 4 medications. We use DPP4 inhibitor plus SU. We use DPP4 inhibitor plus pioglitazone, plus you see some patients, advanced cases, we use sometimes 5 medications. We use sometimes 5 medications plus basal insulin. I will show you in my case presentation, but I prefer DPP4 rather than glycoside.
So that might answer also the question that we will see in the cases, because one of the questions is a patient on triple therapy, sulfonylurea, DPP4, and dapagliflozin, how to manage this patient. I think
we will discuss it during case presentation.
Yeah. There is a question about the risk of fasting during pregnancy.
Yes. Pregnancy, as we mentioned, gestational diabetes treated with insulin or SU, they are very high risk patients and they must not fast. However, gestational diabetes or diabetic pregnancy controlled by diet alone or metformin considered to be high risk patient and they can fast. But they high-risk patients and should not fast. But the majority of patients, in my experience, who are treated with metformin and diet alone, they do fast. And in practice, the risk is minimal in practice.
Should pre-diabetic patients still take their medications pre-diabetes?
Patients with pre-diabetes?
I assume that you give them something for their pre-diabetes. Should they continue taking them during Ramadan?
I think they should be continued. The medication which is given for pre-diabetes, usually it is metformin and pioglitazone. And both of them, they are safe during Ramadan and there is no dose adjustment.
Okay. Do you recommend rhizodic insulin instead of intensive insulin program in type 2 diabetes during Ramadan?
Well, I have my own opinion regarding rhizodic. Really, it has no actually, there is no large difference between degludec and insulin glargine. Rhizodic, it is a combination of degludec plus aspart, insulin aspart. But I do not like, usually in my practice, I do not like combination because it is fixed dose combination. In my practice, I like to give as example basal insulin alone and rapid acting insulin alone to adjust each of them separately. As example, I give glargine at iftar, and I give aspart or apidra at iftar in large dose to cover usually the iftar in our country. It is a heavy meal with a lot of carbohydrate, and there is a high chance of elevation of blood sugar after iftar. Therefore, I give high dose of rapid-acting insulin plus basal insulin like glargine at iftar, and at suhoor, I give only small dose of aspart or apidra at suhoor. It is better regimen than fixed dose of like Rhizodate.
I think, Dr. Mohammed, we shall proceed to the cases and leave the other questions for after the cases. They might be answered during the case presentation.
Yes, okay. The first case. Obese lady, age 53, with body mass index 36, duration of diabetes 5 years, presented before Ramadan with HbA1c 7.1. Her current medication, metformin 850 milligram 1/3, and the glimepiride 4 milligram 1/2. There is no previous episodes of hypoglycemia. She is a housewife. What is your advice to her in Ramadan? This patient is controlled, HbA1c around 7.1, on SU plus metformin, and no episode of hypoglycemia. She is grossly obese, body mass index 36. Here we have a lot of answers. Do not fast due risk of hypoglycemia with SU. Can fast with the following adjustment. Keep the same as far as HbA1c is good pre-Ramadan. Reduce glimepiride to 1/1 and keep metformin 1/2. Shift to DPP4 inhibitor plus metformin. Shift to DPP4 inhibitor plus ribaglinide at iftar. Shift to DPP4 inhibitor plus DABA at iftar. Shift to DPP4 inhibitor plus metformin plus gliclazide at iftar. We have a lot of choices. Maybe more than one answer is correct, but we trying to find the best answer. I think, to me, the best answer here, the patient on second generation SU, and it is a low risk patient, a low risk category, and she can fast in Ramadan. Particularly, she is obese, and obese patients, they do have little bit less risk of hypoglycemia in comparison with lean patients. The best answer in such case, it is here. I prefer in my practice such to switch those patients on SU to DPP4 inhibitor 1/2 plus loading dose of ribaglinide at least 2 milligram 1/1 on iftar alone. And I instruct my patient to check blood sugar at 10 p.m., 12 midday, and 6 p.m. And for the first 3 days, and to call me by telephone about their blood sugar profile and to adjust the dose if it is necessary. Any strategy must be tested during the first 3 days, whether it is correct or not. Adding dapagliflozin on top of DPP4, it is not good strategy. There is no synergistic effect between them. Adding DPP4 inhibitor plus gliclazide, again, gliclazide, it is a long-acting agent, and there is a risk of hypoglycemia during the day. Just to reduce the dose of glimepiride to 1/1 and keep metformin, definitely with this will lead to rise of blood sugar. And our goal in Ramadan is to minimize the risk of hypoglycemia, but not on the expense of rising blood sugar, not on the expense of hyperglycemia. We should be aware also not to rise random blood sugar postprandial, particularly after iftar, and at the same day, not to induce hypoglycemia on the next day, particularly after 12 midday. Any question regarding this case presentation?
No, I think just one said on the chat that he would think 3 or 4, which is reducing Amaryl, and you answered that you would rather shift him to DPP-4.
This one, reduce Amaryl 1 by 1, keep metformin?
Yeah.
I think the patient was on 2 tablets glympyride before Ramadan and 3 tablets metformin. If you reduce the dose to 1 tablet of glympyride and reduce the dose of Amaryl, definitely sugar will go down.
Thank you. We proceed to the second case.
Yes. Obese male patient with body mass index 37, grossly obese, duration of diabetes 5 years, non-compliant with medication, neither with diet. He is eating just 1 meal the whole day. Episodes of hypoglycemia reported, HbA1c 9.5, poorly controlled, current medication, gliclazide, 2 tablets a day, and metformin, 1 gram, 2 tablets a day, presented before Ramadan for your advice. What is your opinion? As far as there is an episode of hypoglycemia, fast is not recommended at all. Very high risk category. Furthermore, high HbA1c before Ramadan considered to be high risk category because he is poorly controlled before Ramadan and there is an episode of hypoglycemia. Therefore, the ideal thing is not to fast. However, if the patient insisted to fast, what to do with them? As I mentioned, our job is to minimize the risk as much as we can, the risk of hypoglycemia, and also to keep blood sugar controlled as much as we can. We have a few choices here if the patient insisted to fast. Can fast on the same Rx plus adding pioglitazone, can fast plus adding DPP-4, can fast plus adding dapagliflozin, can fast plus adding basal insulin, glargine, can fast plus adding liraglutide, shift to DPP-4 inhibitor plus dapagliflozin on iftar plus ribaglinide 4 milligram on iftar. What is your opinion? I think as far as we don't have voting system here and it is not live presentation, I will just do my comments. The ideal thing here is not the patient, he must not fast. This is according to the guidelines. However, if he insisted to fast, I will go for the last regimen, DPP-4 inhibitor plus dapagliflozin on iftar plus ribaglinide. You remember the patient, he is on 2 medications and his HbA1c 9.5. And he has episodes of hypoglycemia. And he is not compliant with diet at all. Remember that. Therefore, we must instruct the patient to adhere to diet. I usually instruct my patient to divide the meals in Ramadan at least 3 meals, 1 meal at iftar, with low carbs, low fat, and another meal at 11 or 12 midnight, and another meal at suhoor. At least 3 meals, not only 1 meal, as some patients, they are claiming they are not doing suhoor at all, just iftar and that's it. You will never control diabetes with just 1 meal the whole day. Therefore, if the patient insisted to fast, I will not give pioglitazone for simple reason, because until pioglitazone, it will take its effect, it will take 1 month or 2 months. Therefore, it is not ideal at all to give pioglitazone at Ramadan. If the patient were on pioglitazone before Ramadan, it is good idea, but to add it on at the onset of Ramadan, it is bad idea at all. To add DPP-4 inhibitor alone on top of gliclazide and metformin will not bring you HbA1c from 9.5 to 7%, just adding DPP-4 inhibitor. The same applied if you add the dapagliflozin on top of this regimen, you will never achieve HbA1c of around 7%. Adding basal insulin, glargine, on top of glycoside and metformin, there is further risk of hypoglycemia with the glargine. And the glargine, usually insulin, it is appetizer, and he will eat, and there will be a lot of post-iftar hyperglycemia, and the risk of hypoglycemia will be more. Can fast plus adding liraglutide, as we mentioned, it is bad idea to add liraglutide at the onset of Ramadan because you have to titrate the dose very gradual, and this will take around 3 weeks at least, and Ramadan will almost gone. The last choice is the option of choice. You shift the patient completely to combination of DPP-4 inhibitor plus metformin, 1/2, 1 at iftar, 1 by suhoor, like vildagliptin as example, plus metformin at iftar and suhoor. Then you add dapagliflozin at iftar, and you add high-dose ripaglinide. Ripaglinide, it is secretagogue, it is short-acting, rapid-acting. It acts actually from iftar to suhoor. I do not give it as suhoor, I just give it to iftar to cover usually a very heavy iftar. I give a large loading dose. I think with this regimen, we can both combine reducing the risk of hypoglycemia, and we can manage to bring HbA1c to 7%.
There's a
Any question regarding this?
There's a question about if you can't achieve a normal blood sugar during fasting, what do you accept usually? As I think you mentioned, it is 70, below 70 you break the fast, after above 300 you break the fast, isn't it, Dr. Mohammed?
Yes.
Yani this is the level that you accept.
We have to keep blood sugar as much as we can in a good range. Usually, I think good range if fasting blood sugar 100 to 140, random blood sugar, I think up to 180 it is accepted in Ramadan. Okay. Random blood sugar.
There's a very interesting question. Actually, he is thanking you for the interesting presentation, and he is asking about those who underwent bariatric surgery to improve their glycemic control. What is your recommendation for them that they can't eat as normally as on the fast? If they you recommend them to do you recommend them to fast? How often to eat? What to eat?
Yes, it is very interesting question.
Yeah.
Regarding patient who already done bariatric surgery, particularly bypass surgery, they are prone to hypoglycemia. Therefore, if there is any episodes of hypoglycemia in the first 3 months before Ramadan, I think they must not fast. If there is no episodes of hypoglycemia, they can fast, and usually the majority of those patients, they are cured without any medication. The majority, I mean. But if still there is a residual medication, usually it is applied only to metformin and DPP-4 inhibitor. I don't think after bariatric surgery, any patients need SU or need GLP agonist or will need insulin. I don't think so. Therefore, they can, if there is no episodes of hypoglycemia before Ramadan, they can fast, assuming they are on diet alone or on metformin and DPP-4 inhibitors. They can fast, or dapagliflozin, SGLT2 inhibitor, they can fast, yes.
Thank you. There's a question about type 1 diabetes who started using insulin. What do you suggest for them?
Regarding type 1 diabetes, poorly controlled diabetes, they are very high risk category, and they must not fast. If the patients with type 1 diabetes is excellently controlled before Ramadan, they still in high risk category and they should not fast. However, if they insisted to fast, I allow, if the patient well controlled before Ramadan, he can fast, assuming he is on basal bolus regimen. If he is on premixed insulin, I shift him to basal insulin like Glargine and rapid-acting insulin like Aspart or Apidra. As I mentioned, I give 1 dose of long-acting insulin, basal insulin on iftar, and I usually reduce the dose. It is calculated the dose according to body weight, of course, in type 1 diabetes. Usually we calculate the dose of insulin according to body weight. We give usually in lean patients, we started with 0.6 to 0.7 units per kg. In a little bit obese patients, we start with 0.91 units per kg. And we divide the whole dose, 50% of the dose, it is for basal insulin, and 50% of the dose, it is for rapid-acting insulin. And we divide the Ramadan rapid-acting insulin in 2 doses. Usually on iftar, it is 2/3, and on suhoor, 1/3.
Thank you. Shall we proceed to the further
to the
fourth case? Yeah.
First presentation. Obese gentleman, 63 years old age, with body mass index 32, duration of diabetes is around 9 years. DBB, he is on triple therapy, DBB4 inhibitor by 2 and glimepiride 1 by 2. No history of hypoglycemia. He is on 3 meals, 3 snacks. He is very polite. He is a very disciplinary patient. He has also ischemic heart disease, 2 stents, hypertension, hyperlipidemia, but he has normal kidney function and no heart failure. No, he is not taking diuretics. His HbA1c, for his status, it is, I can assume he is controlled, 7.5. Can he fast in Ramadan? If so, any modification to his current regimen? The patient fast is not advised due to existence of ischemic heart disease, 2 stents. The patient can be included in high-risk category because the existence of ischemic heart disease, hypertension, hyperlipidemia. But if the patient is insisted to fast, as far as his coronary artery disease is stable, he can fast, but we have to do this modification to his medications. Reduce glimepiride 1 by 1, reduce glimepiride 1 by 1, and add SGL2 inhibitors. Reduce glimepiride 1 by 1 and add Glargine. I think initially one must tell the patient the truth that he is a high-risk patient and should not fast. But if you, as a physician, feel that he is keen to fast, I think we must accept that. And the best answer here is to reduce glimepiride to 1 by 1 and to add SGL2 inhibitor for the benefit of cardiovascular events, for reduction of cardiovascular events. And of course, if you reduce glimepiride to 1 by 1, you expect blood sugar will rise up because he was previously on 1 by 2 glimepiride and DBB4 inhibitor. We keep it the same, but we reduce glimepiride to 4 milligram 1 by 1, and I will add SGL2 inhibitor on top of that. With this regimen, we can ensure that the patient no hypoglycemia, and at the same time, we can keep his blood sugar control. And at the same time, we're adding SGL2 inhibitor, we can reduce the risk of cardiovascular events. I think this is the best question. Adding Glargine is not a good idea because Glargine on top of glimepiride will increase the risk of hypoglycemia. Any question to this?
No, Dr. Muhammad, but I'm wondering why wasn't he already on SGLT2?
The patient wasn't on SGLT2 inhibitor before. It is ideally he should be before on SGLT2 inhibitor, but sometimes a lot of patients, they are referred even from cardiologists who are giving this, and they are inserted this stents to the patient, and still the patient is not on SGLT2 inhibitor, unfortunately. This is a common practice till now. In my opinion, SGLT2 inhibitor in our country, they are given to patients who are not a good candidate, but patients with the proven benefit and the strong candidate, they are not giving to, unfortunately. Let's go to the fourth question. For case presentation.
Yeah.
Old lady with diabetes, 17 years, long-standing diabetes, mild renal failure, her eGFR 50, HbA1c 9, poorly controlled. She is not obese. Current regimen, mixed-ard, 25 units by 3. There is episodes of hypoglycemia and hyperglycemia as expected with pre-mixed insulin. She insisted to fast in Ramadan. What is your advice? Renal failure plus poorly controlled diabetes pre-Ramadan on multiple insulin injection constitute a high-risk category and should not fast. Remember that the patient poorly controlled diabetes before Ramadan, she has renal failure stage 3, and she is on multiple insulin injection. There is episodes of hypoglycemia before Ramadan, and all those, she must not fast at all. She is very high risk or high risk category and should not fast. But the patient insisted to fast. In such case, she needs a frequent glucose home monitoring, liberal fluid intake with these modifications of her insulin regimen. I usually shift all patients on premixed insulin to basal bolus regimen. I shift her to glargine on iftar and 2 shots of aspart on iftar and suhoor. The same regimen plus adding SGLT2 inhibitor on iftar. 2 shots premixed insulin 50-50 on iftar and suhoor plus SGLT2 inhibitor on iftar. Premixed insulin 50-50 on iftar and suhoor plus glargine on iftar. What is the best choice for her? As we mentioned, initially, we must convince her not to fast because she has previous episodes of hypoglycemia. She is on multiple doses of insulin injection. She is poorly controlled before Ramadan. She has renal failure stage 3. All of those constitute a very high risk and high risk category. But if the patient insisted to fast, I will go for this regimen. I will go for shifting her to basal bolus regimen as a glargine, as example, to give her on iftar, and 2 shots of aspart on iftar and suhoor, as I mentioned before, and to add SGLT2 inhibitor on iftar for kidney protection. Although no clinical trial done in Ramadan, but I think the guidelines will be changed sooner or later for the benefit of SGLT2 inhibitor for patients with a diabetic chronic kidney disease. At the same time, I will instruct her to take liberal fluid intake and the frequent glucose monitoring. Such patient will need not 3 blood samples. She needs maybe glucose home monitoring of 5 at least to be sure that the regimen is adequate. Regarding other options, shift 2 shots premixed insulin 50-50. I don't think it will control her diabetes and will give her risk of hypoglycemia. And also premixed insulin, iftar and suhoor plus glargine also will give the patient at risk of hypoglycemia on the next day. We will control hyperglycemia after iftar, but on the next day, definitely there is a high risk of hypoglycemia. Therefore, I am not in favor of this regimen. My favorite regimen will be glargine plus 2 shots of iftar and suhoor, and adding SGLT2 inhibitor for chronic kidney disease for kidney protection. Any question regarding this case presentation?
There are no questions, but I would like to ask you, Dr. Mohammed, in such a case, she is such a high-risk patient, and she is jeopardizing her kidneys and all other systems. Don't you think that we, with the imams and the can help in making them understand that she should not fast at all?
Of course, this is my favorite first one. But
I don't think
that the patient is insisting, you see, our goal, as I mentioned, is to convince the patient as much as we can. But at the end of the discussion, if you feel that the patient is keen for fasting despite your talk, I think just to tell the patient, you are not good candidate for fasting, go and do not fast, and that's it. I think it is not good strategy. I think if at the end of the discussion, you have a feeling, internal feeling, that the patient will fast whatever you talk to him, whatever arguments you are talking about, he will fast. I think the best idea is to minimize the risk and to give him the best regimen to minimize the risk of hypoglycemia and the risk of hyperglycememia at the same time. Such patients, I usually do also instruct them to do kidney function test 1 week after starting the regimen, and also 2 weeks after starting the regimen to ensure that there is no deterioration of kidney function. Of course, you expect if you're adding SGLT2 inhibitor, there will be a decline of eGFR of about 5 ml per minute in all patients with whether they have chronic kidney disease or healthy patient. There will be a decline the first 3 months, but then there is a stabilization. But if you feel there is a decline more than that, you can stop SGLT2 inhibitor and keep the patient on insulin alone. Is there any question regarding this case? Audience? Dr. Taroub?
We are a little bit more liberal in giving the SGLT2. What about treatment for hypoglycemia? I think. What about treatment for a hypoglycemia? This is the last question, he says. How do you treat the hypoglycemia in Ramadan? Does it differ than treating hypoglycemia any other time?
I don't think so. Of course, we are instructing all patients to break the fast if blood sugar goes below 70 mg/dL. And if this continue more than once, despite adjustment of all our dosages of insulin, I instruct the patient to stop fasting the whole month of Ramadan. But the treatment of hypoglycemia, I don't think it is different in Ramadan rather than other months of the year.
Thank you, Dr. Mohammed. I don't think we have any more questions. We just have compliments that it was a very nice lecture, and they are all thanking the speaker.
Left. We have 2 cases, or to finish.
Let's proceed if they agree. Yalla, let's go on.
Yeah, 2 cases we have more. Young female, 35-year old age with gestational diabetes, body mass index here 30, undetimer 20 units AM, 15 units PM, and metformin 850 milligram. She is controlled 60, HbA1c 6.2. She needs your opinion regarding fasting in Ramadan. As we mentioned before, patients with gestational diabetes who are insulin, they are included in very high risk category, and they must not fast. They are in the first category. They must not fast. However, a lot of patients, they insisted. In case she insisted to fast, she can fast with the following adjustment. In such case, if she insisted to fast, add aspart on iftar, increase ditimer on iftar, reduce ditimer on suhoor, and keep metformin 1/2. Shift to premixed insulin 50/50 on iftar, plus 20 units of ditimer on iftar and 10 units of ditimer on suhoor. Keep metformin. Shift 1 injection of glargine plus metformin 1/2. The best answer is the first one, that you have to convince the patient not to fast. She is very high risk patient. But again, if I feel that the patient is insisting to fast, I will go for this regimen. I will add aspart on top of ditimer at iftar, because usually the iftar is heavy meal in our country. And to prevent postprandial hyperglycemia, I will add aspart and decrease. I increase ditimer on iftar to cover the period from iftar to suhoor. And I reduce ditimer on suhoor, and I will keep metformin 1/2. This is the best answer if the patient insisted to fast on Ramadan. What about premixed insulin? I don't like to use premixed insulin at all, whether during Ramadan or without Ramadan. I don't like to use premixed insulin. Adding glargine, I don't think it is the option of choice in Ramadan. Usually the option of choice is ditimer. Any questions regarding this case?
There are no questions about this case.
No question. Last case presentation. Yes. 52 years old age, overweight, diabetic male patients with abdominal obesity, body mass index 30, duration of diabetes 9 years, on DB4 inhibitor, glimepiride by 2, pioglitazone. Actually, he is on 4 medication, and still HbA1c 8.9, poorly controlled. No ischemic heart disease, no kidney function normal, no hypos. Can he fast in Ramadan? If so, should you interfere with his regimen? Answers. Patient already on 4 medications and is still poorly controlled. Further deterioration of his blood sugar is anticipated during Ramadan. Should not fast. He is high risk category. Yani category number 2. He is high risk, poorly controlled, despite he is on 4 medication. Again, if the patient insisted to fast, I will instruct him regarding diet. Strict diet must be emphasized. 3 meals, less carbs, and fast on iftar, plus the following modification to his regimen. Reduce glimepiride 4 milligram 1/1, add dapagliflozin on iftar, reduce glimepiride and adding glargine on iftar, DC glimepiride at all, and give him a Humalog mix 50/50 on iftar plus dapagliflozin. What is the best answer for him? Of course, as I mentioned, the patient included in the high-risk category, category number 2, and he should not fast because he is poorly controlled even before Ramadan on 4 medication. But fortunately, he has no episodes of hypoglycemia before Ramadan, and he has normal kidney function and no ischemic heart disease. Therefore, I think if the patient insisted to fast, I think we can allow him with the proper instruction regarding that, and also regarding frequent monitoring of glycemia with glucose home monitoring. In such case, reducing glimepiride to 1 by 1 and adding dapagliflozin iftar, this choice will reduce the risk of hypoglycemia, but I don't think adding dapagliflozin will bring his HbA1c from 8.1 to 7%. Therefore, I don't think it is the option of choice. Reduce glimepiride 1 by 1 and adding glargine on iftar, I think also it is not a good choice because adding glargine, it is long-acting insulin, I think could precipitate hypoglycemia on top of SU. DC glimepiride at all, add the Humalog Max 50-50 on iftar plus dapagliflozin. I will go for the last regimen, personally. The Humalog Max, it will act around 8 hours only. It covers iftar good because here the ratio, it is 50-50, it is not 70-30. And it will cover the period from iftar to suhoor with assuring that there is no postprandial spikes after iftar. And adding dapagliflozin also on top of pioglitazone and DPP-4 inhibitor, you ensure that after suhoor, the patient no risk of hypoglycemia and he will be controlled better. I think this is the option of choice for him. Is there any question related to this last presentation?
There are no questions related to this, and I think with this we can say Happy Ramadan to all. Thank you, Dr. Mohammed, for this very informative lectures. The cases, everybody liked the cases. There are a lot of chats about them. And on behalf of Dar al-Dawa, I would like to thank all the participants and wish them Happy Ramadan.
Thank you very much, Dr. Taroub. Thank you, Dar al-Dawa, for sponsoring this activity. And thanks to all participants of this lecture with this webinar. And happy Ramadan, happy iftar. And thank you very much for listening. Thank you.
Thank you so much. Thank you all for attending. Thank you, Dr. Mohammed, for this informative, valuable lecture. You always make sure to enrich us with your great knowledge. And thank you so much, Dr. Taroub, for adding your magic to make this lecture more interactive. Thank you all and see you soon, inshallah. Have a good night.
Thank you all. Thank you. Thank you, Balsam. Thank you.
Thank you.
And then we can end, yeah?
Yes.
تفضلوا على السحور.
Thank you very much.